Welcome, everyone. We're just going to get started in a few minutes. Okay, well, I'm going to go ahead and get started so that we stay on time because I have time on my watch. Well, welcome. My name is Vivetta Lobo. I am an ER doc out at Stanford. I'm also an ultrasound director there. It's nice to see a lot of familiar faces. I am moderating this session today. This is, just so we all know, we're in the right room. This is the live presentation, oral abstracts on education. We have 6 fantastic abstracts that we're going to go over today with presenters, so I'm really excited. Also want to introduce Kelsey, who is our medical student ambassador and kind enough to help out today. So we're going to start in 30 seconds with our first presentation to stay on time, but just a few logistical stuff. Everyone gets total 12 minutes, out of which you have 10 minutes max for presentation. And then the remaining 2 minutes or more will be towards your Q&A. If we have extra time at the end, I'm happy to add some more Q&A time if people have questions. I will ask that if you do have questions for our presenters, which please do have some, we will add it in please add it in the chat, and Kelsey will kind of keep mindful of them so that when the time comes, we can get them asked. All right, so without further ado, all right, so we're gonna start our first. Oh man, I have to say your last name now.
Okay, don't worry about it.
We're going to start with my colleague from Stanford. It's Dr. Prokryos.
Oh, it was pretty good.
That's pretty good. Okay. Who's going to talk to us about med mastery and central line insertion? Nick, it's your time.
All right, let me see. Let's see. Does everybody see that well? Fantastic. So hi, everyone. Today, what I'm going to do is I'm going to be presenting our work today titled Mastery Learning Improves Performance of Central Venous Catheter Insertion by Academic Emergency Physicians. I have no disclosures or conflicts of interest to report. And so in terms of some background on this project, so we generally assume that attending physicians are experts at performing procedures by the time they complete residency training. And so, our question is why? There are several reasons to think otherwise. So first off, there's a historic lack of standardized objective training for procedures when you look across training programs. Competency is determined primarily through teaching faculty evaluations, which can be variable and subjective. And numerous studies really demonstrate substantial variability of resident performance when it comes to procedures. ABEM does also not perform competency assessments either during initial certification or during maintenance of certification. And there are some studies, most notably by Jeffrey Barsak and colleagues, that show similar findings in terms of variability and substandard performance among attending physicians, and that includes in emergency medicine. And to give you an example, one study looked at a large cohort of attending physicians within the VA system, looking specifically at central venous catheter insertion, and only 18% met a minimum passing standard when they did their assessments. And really the last point is, are academic faculty more vulnerable to skill attrition because of the presence of trainees and their lack of ability to routinely practice their own skill when it comes to these procedures? So, simulation-based mastery learning has really become or emerged as a gold standard for procedure training that's objective. It's time variable, it's outcome determinant, where all participants must reach a rigorous minimum passing standard to be able to advance. And the best evidence on its impact is also from Jeffrey Barsak and colleagues, and it's on central venous catheter insertion. And what they saw was that when they implemented a central venous catheter simulation-based mastery learning program at their institution, they actually saw improved translational outcomes, including things like increased rate of first-time success at the central line insertion, decreased rate of arterial punctures, and probably most notably, a decrease in central line associated bloodstream infections throughout their hospital when they implemented this program. So, we wanted to have a study that answered the following questions. First off, what is the baseline central line insertion performance of academic EM faculty specifically? Are there any factors that predict central line insertion performance, such as time since completion of training, with the idea that skill decays over time? And does a simulation-based mastery learning intervention improve performance specifically in this population? With our hypotheses being that central line insertion among our population was going to be variable, it was still going to be suboptimal. An increased time since completion of training, so the further out you were from completing residency, would have decreased performance, really based off of just skill decay and lack of practice opportunity. And again, that our simulation-based mastery learning intervention would improve performance of those that were substandard. So for our methods, we submitted this protocol to our institutional review board, which exempted it as an educational intervention. This was a simple pre-test, post-test study design looking at ultrasound-guided internal jugular central venous catheter insertion. We used a commercially available task trainer that allowed realistic performance of a central line insertion, a complete central line insertion, as well as a bedside ultrasound. And our subject population was volunteer emergency medicine faculty physicians at our institution, with really the only exclusion criteria being if you were on personal or professional leave. Our intervention was a simulation-based mastery learning intervention. We performed this intervention from July 20th to August 10th last year. And we used a previously validated checklist, the same checklist that was used by Jeffrey Barsick and colleagues, that contained 29 items that were all relevant to central line insertion. And we also set our minimum passing standard at 98%. And again, this was based off of a published study that was looking at varying standard setting approaches. And this particular one used the most rigorous, which was the Mastery Angoff standard setting approach. And for those of you that aren't familiar with that, it really asks standard setters the question, what proportion of well-prepared learners would be able to accomplish each one of these items? So, and for our actual intervention, this was a pre-test, post-test performed on the same day, generally speaking. Participants were allowed to come in. They would get a baseline assessment. They would get direct feedback from an expert reviewer or expert assessor, would be allowed time for deliberate practice, and then undergo post-test the same day. If they failed post-test, they were allowed repeat practice opportunities and repeat testing assessments until they met the mastery standard, or until, unfortunately, we just ran out of time. So for our results, we had 44 faculty participants in this study group, which accounted for roughly half of our clinical faculty at our institution. Our mean pre-test score was 79.7%. At baseline, only 4 out of 44 participants met the minimum passing standard. And performance, or your baseline performance, was predicted by years out of training, and I'll get to that in a second. After our intervention, of the 40 that did not meet the minimum passing standard, we were able to get 33 up to that mastery level. And I'll go over the limitations of that in just a second. And overall, scores increased by 21.5% with following our intervention. So this table is just looking at the demographics of our group. We had an equal distribution of participant sex. We also had a pretty good distribution of career levels among our faculty. And this is a box plot demonstrating the differences with baseline assessments compared to years from postgraduate training. And so what we did in this analysis is we dichotomized those that time since completion of training, with the first group being up to 5 years since completion of their residency, and the second group being 6 or more years. And you can see there was a difference. The first group, the average pretest score was 84.6%. And for the 6 or more years group, it was 76.0%. And that was significant with a p-value of 0.023. This is a dot plot that demonstrates our results pre-test and post-test. And what you can see is that participants had a pretty normal distribution on pre-test with a pretty wide range of scores. I believe our minimum score was something like 48%, and 4 participants up there at the top reaching the minimum passing standard. And then you can see in our post-test group, most people did reach the minimum passing standard. We did have a handful that got up, maybe missed one or were one item below our minimum passing standard, with a couple that did not quite make that top mark. So, in conclusion, we found that our study group had substandard variable performance when it came to central venous catheter insertion. There was an association with that participants had decreased baseline performance with increased time since completion of training, and that our simulation-based mastery learning intervention did improve performance, with the limitation that, contrary to the goal of simulation-based mastery learning, not everyone met the minimum passing standard. And the limitation there is that it's very difficult to get faculty who are already very busy to come back and do repeat assessments when they are very limited by time. The limitations of our study really were primarily, I think, related to study design. This is a quasi-experimental study design without the use of really control groups. So we are limited by the lack of controlling for confounders. Time, as I mentioned, is a very valuable resource for academic faculty, and so it didn't quite let us achieve the true mastery learning goals. And there are additional covariates, certainly, that could impact at least baseline performance, one of which is the number of central line insertions either performed or supervised clinically. That is something we're looking at and plan to include in our eventual manuscript. And so with that said, I will say thank you for listening and answer any questions that you have.
Thank you, Nick. That was exactly 10 minutes. Good job. I have a question, but I was going to give it to preference to the chat. Does anybody have any questions? I don't see any. Does anybody have a question they would like to ask? If not, I have a question for you. So being in that I'm in the camp of the greater than 5 years out for residency, in a way to defend my crew, I was just trying to think of other things besides, what we traditionally think of procedural decay or skill decay, that might have played an impact of why, they didn't perform as well. If there were thoughts, I have a couple of things that came to my mind, but I was wondering if there were any other thoughts that you had about that.
Yeah, certainly, one thing that I thought could impact those numbers was the presence and use of ultrasound. And a lot of, in particular, maybe not the 5-year or like 6-year group, but I'm talking more like the 20-year group, might not have performed as well because of ultrasound technique. I will say we did look at that as well. And in reality, most people actually did pretty well on the ultrasound portions of the procedure. Things that were missed a lot more commonly were things like remembering how deep to insert the guide wire or the actual catheter, stuff like that.
So more actual procedural stuff.
Right. And a little bit more of like the knowledge retention of these specific measurements.
Right. That makes sense. Well, I'm glad to hear that everyone knew the ultrasound. That's good to know. But the other thought I had was just the fact that it's on a simulation training assessment.
Oh, absolutely.
Module, right? Because, when I trained, we started doing a little sim towards the end of my residency, but I'm sure people before me didn't practice on it as much. And so there's that concept was also kind of novel. So I was wondering if that.
Yeah, very good point.
Cool. All right. If there's no other questions, I'd like to stay on time so we can move forward. Our next presenter is Dr. Megan Mitchell from University of Michigan.
Yeah, hi. Let me just share my screen.
Thank you.
Can everybody see that?
Yep.
Okay. You said, so I'm Megan Mitchell from the University of Michigan, and today I'll be talking to you about a study we did on geographic mobility within the emergency medicine match and the influence of gender. I have no disclosures. We'll start with just a little bit of background on why we thought this topic was worth looking at. Year to year, about 50% of medical students, and in 2020, 37% of EM applicants are women. But women are disproportionately underrepresented in higher ranking medical school positions like full professor, chair, and dean. And over 35 years, the number of women in academic medicine holding the role of full professor, a position that's generally a predecessor to administrative leadership roles, only rose from 7% in 1976 to 13% in 2010. And in 2010, women in leadership positions represented only 21% of division and section chiefs and 11% of deans. It's been shown that at the faculty level, geographic mobility correlates with academic advancement, and that difference can be shown as early as the first job after residency, with the odds of promotion being 168% higher for movers than stayers, and movers attaining a higher administrative position within their organizations. So we wanted to compare the geographic distance traveled between medical school and residency by gender, with the hypothesis being that women will travel a shorter distance than men and that this may have future career implications. So we did this using a multi-center retrospective cross-sectional study with the NRMP lists of ranked applicants from 8 geographically distinct programs. We obtained permission from the NRMP to use this in a de-identified fashion, and it was IRB exempt. Those 8 programs were a convenient sample of a mix of 3- and 4-year, primarily academically focused programs. We used the AAMC ID as a unique identifier, and then the gender as expressed in the interview was assigned by the program director. We then added the medical school street address using the AAMC or AOA listing and the residency program address from the ACGME listing. We then ran it all through ArcGIS Pro to map origin and destination and compare by gender. We ended up with 944 unique individuals from those 8 lists. From there, we excluded 63, either because they went unmatched, they matched into a specialty other than emergency medicine, they were an international medical school graduate, the gender was unknown or conflicting between lists, or they went to medical school in Hawaii. And we excluded the Hawaii students because they're forced to travel a large distance because there's no training on the island, and so they became an outlier in the data set. So this left us with 881 unique individuals for analysis, which represented 37% of all matched seniors in 2020. And of those 881, 420 or 38% were women. We found that on average, women traveled 623 miles with a median distance of 342 miles and a standard deviation of 703 miles. While men traveled a mean of 653 miles, a median of 316 miles and a standard deviation of 741 miles. And you can see that the distribution of the data is pretty similar between the 2 genders. This histogram just shows the frequency of distance traveled by gender broken up in 50-mile increments. You can see that the majority of individuals stay within their geographic region, with frequency decreasing pretty significantly after around the 350-mile mark here. This is a map of all of the EM programs that were active in the 2020 civilian match, and it compares programs that we have data for and programs not represented in our data set. The pink dots are programs within our data set, and the white triangles are programs not represented. We had a total of 158 out of 246 programs represented in our data set, which is about 64%. And the geographic distribution is pretty similar, primarily along California and then the Northeast and the Midwest. So our main conclusion from this study is that there's no difference in this sample between men and women in the distance willing to travel from medical school to EM residency. Our sample is subject to bias as women are overrepresented here relative to the global applicant pool, 48% in our sample and 37% in the global applicant pool. We also only have data from academic programs. And while this fits with the idea that academic programs tend to shunt people into academic careers, there might be a difference for more community-based sites. So we can say it's likely that geographic mobility is less likely a constraint at this career stage, but it's unclear how big a role gender plays in that. There's a 2016 research study that evaluated business school graduates, which we can consider to be analogous to new medical school graduates, which failed to show a difference in the willingness to relocate based on gender or family status, but did show an increased likelihood based on personal psychological characteristics. This is pretty similar to a 2012 German study that found personality factors such as higher levels of tolerance of uncertainty, individualism, and openness to new experiences were stronger predictors of willingness to relocate than demographic factors. Based on some work by Jordan and team in 2018, we can speculate that personality characteristics that facilitate geographic mobility might be more present within the emergency medicine applicant pool compared to other specialties, and that this, combined with the opportunity for mobility at a critical career juncture, might account for the lack of gender differences that we saw in our study population. We did have a few limitations to our study, especially that there are multiple factors that can influence relocation decisions, such as couples matching, being in a committed relationship, or having family ties to an area, and we couldn't account for any of those. We also had to use a binary gender assignment and can't identify people who may be gender nonconforming or who identify differently than the gender expressed on their interview day. And those gender assignments were done by program directors after the interview and might be subject to error and recall. Although during the data merge, we were intentionally alert to discordance between assigned gender between programs when an applicant showed up more than once, and we didn't see that in any case. We also already kind of talked about how our data is from academically focused sites and that there might be differences present in community-based sites that we're not seeing. And we also only have 1 year of data, so there may be dynamic trends that vary year to year that we failed to capture. Some of the areas for future study would be to assess motivating factors within the EM match, which may facilitate a significant geographic move, either dictated by organizational characteristics and career opportunities or community and proximity to family support. It may also be interesting to repeat these methods with graduates of some of the residency programs represented here and the distance they travel for their first job, and see if there is a difference at that career stage. And that is all I have. I'm happy to take any questions.
Thank you, Dr. Mitchell. Is there any questions from the group? Megan, can you clarify? I think I missed it. What cycle year was this, the applicants, the year that you guys looked at? Was it for starting residency in 2020 or?
Yeah, it was the 2019-2020 match. So it was the 2020 match year.
I was just curious if COVID had an impact or not, but I guess it was the year before then, which would be cool. Okay, any questions for Megan? The only question I had really on my part was, you started out talking about women in leadership positions and kind of how there's an very clear underrepresentation. And, the study, with its limitations, I understand, kind of didn't show much difference between men and women as far as geographic mobility went. So did you have thoughts as to maybe other factors that might be other areas that you could pursue in order to try to answer that question that you initially started with?
More factors on like why women are underrepresented.
Right.
Yeah. I think there's a lot of things that we failed to capture. And one of the things we had talked about were if women in leadership positions within the residencies influence a female applicant's desire to go to that program, and we weren't able to capture any of that. Or if people are more interested in going somewhere that's either closer to home or puts them in a position to kind of long-term be in a geographically desirable region. But we didn't have a lot of the data to like look more at that pipeline.
Right. And then for the folks that did end up not traveling, your subset group that didn't travel as much compared to those that did, compared to your mean miles that were traveled, were there any obvious factors as to why they chose not to?
We didn't see any significant difference between those groups in our like sub cohort of people who traveled under 50 miles. There wasn't anything that we could identify.
Okay, cool. Thank you.
Thank you.
All right. Well, if there's no other questions, we can move along. Our next presenter is Dr. Jamie Jordan from UCLA Medical Center. Jamie, if you're ready.
Hi, everybody. Just give me a second to share my screen here. All right, hopefully everybody can see my screen now. But yes, I'm Jamie Jordan. I'm an associate professor and one of the associate program directors at UCLA. And on behalf of all my co-authors, I would like to present our research abstract, which we titled Chief Resident Status Predicts Post-Graduation Career Path Among Emergency Medicine Residents. We do not have any conflicts of interest to disclose. So as you all know, the chief resident role is well established in medical training and often comes with additional administrative and educational responsibilities, which demand time and effort above and beyond what's generally required of non-chief residents. In return, chiefs often receive additional training and opportunities to develop leadership skills, which can certainly aid them in their future careers. Now, there are many personal and programmatic factors that influence training career paths. However, the impact of the chief resident position on careers in emergency medicine is unknown. So our objective was to evaluate the association between the chief resident role and immediate post-residency position in emergency medicine. So we performed a multi-institutional retrospective study. We reviewed all graduate data from the last 5 years, so 2016 to 2020, at 6 ACGME accredited emergency medicine residency programs. And we purposely selected sites that were geographically diverse and included both 3- and 4-year training formats. Each site collected data using a standard abstraction form that was created by our study team after a literature review and piloted prior to use. And all our abstractors participated in a brief training session prior to abstracting any data. And the data we abstracted included program name, year of graduation, chief resident status, number of publications during residency, and then immediate post-residency career path, which we categorized as fellowship, full-time academic faculty position with a research focus, a full-time faculty position with a non-research focus, community practice without any teaching roles, and then community practice with teaching roles, additional residency training, not practicing clinical medicine, and then other. So for our analysis, we calculated descriptive statistics and used logistic regression to explore differences between the chief resident cohort and other graduates. So on to our results. So we gathered information on a total of 365 graduates, which included 93 chief residents, or approximately 25% of our sample. There was no missing data on any graduates. 167 residents graduated from a 3-year program and 198 residents from a 4-year program. And the mean number of publications completed during residency was 1.6 for chiefs and then 0.83 for other graduates. So this table here just shows the immediate post-residency career path of graduates. And you can see that the majority of graduates went into community practice positions, and 129, so roughly 35%, went into academic positions, including fellowship, full-time faculty with a research focus, and full-time faculty with a non-research focus. There were no graduates in our study who pursued additional residency training or careers that did not include the practice of clinical medicine. So after accounting for program, year of graduation, and number of publications completed during residency, we did find that chief resident status was a significant predictor of immediate post-residency career path. We found that chief residents were more likely than other graduates to enter a community practice with teaching position, fellowship, a full-time academic position with a research focus, and a full-time faculty position with a non-research focus, as opposed to a non-teaching community practice position. And for those who were immediately after residency, their career positions were categorized as other. There was no significant difference between the chiefs